Hello and welcome everyone to this month's Fireside Chat dedicated to raising awareness and fostering understanding about breast cancer in honor of Breast Cancer Awareness Month. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our team's mission is to reduce the burden of cancer in Minnesota by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. My name is Amna Hussein. I am the Community Outreach and Engagement Manager on our team, and I will be moderating our program today. As I mentioned earlier, we unite today in support of Breast Cancer Awareness Month. In this intimate and informative fireside chat, we are privileged to have two incredible women who have dedicated their lives to making a difference in the realm of breast cancer. First, we have the distinguished Dr. Damé Idossa. Dr. Idossa is an assistant professor of medicine and a breast oncologist in the Division of Hematology and Oncology at the University of Minnesota. Dr. Idossa is a native of Ethiopia and immigrated to Minnesota at the age of 8. Dr. Idossa is a passionate advocate for diversity and inclusion and has a long-standing commitment to serving vulnerable populations. Her research interests focus on disparities in cancer care, breast cancer in young women, and increasing access to clinical trials. She also studies workforce development, particularly the mentorship experiences of underrepresented trainees in hematology, oncology subspecialties. Dr. Idossa has received many awards to support her research, including a Merit Award from the American Society of Clinical Oncology and a T32 Research Fellowship from the National Institutes of Health. She has published numerous articles in medical journals related to her research interests. Dr. Idossa's tireless efforts and expertise have been instrumental in improving the lives of countless people. Today, Dr. Idossa's presentation will provide an overview of breast cancer, including the latest screening guidelines, the most recent advancements in treatment, and will touch on her research in breast cancer in younger women and the persistent disparities that we see in breast cancer. Joining Dr. Idossa is the inspirational Steph Kennelly, a breast cancer survivor and passionate advocate. Her story is one of courage, resilience, and unwavering spirit. I will introduce Steph later on in our program today. Before we get started, I want to cover just a few housekeeping items. We will be recording today's session, so you can refer back to the recording on the Masonic Cancer Center's YouTube page and share it widely with folks who you think may benefit from the session or are just interested in learning more. I would like our audience to get familiar with using the Q&A feature, which is located on the bottom bar of your Zoom window. Throughout today's presentation and event, we encourage you to actively engage, ask questions, share your thoughts, reactions, and comments using the Q&A feature. We will have plenty of time for discussion following Dr. Idossa and Stephanie's presentations. For University of Minnesota employees and spouses participating in the University of Minnesota's Employee Wellbeing Program, I'm going to put a link in the chat shortly to complete the survey to mark your attendance today to earn your well-being points. All right, without further ado, I will pass it over to Dr. Damé Idossa. Dr. Idossa, the floor is all yours.
Thank you so much for that kind introduction. Let me just share my screen. Okay, thank you so much for having me for this month's Fireside Chat. I have no disclosures. I will be spending the next 20-25 minutes or so giving you all a very brief overview of breast cancer, some of the updated screening guidelines. We'll talk very briefly about treatment. This can be very complex and honestly can be its own separate talk. So unfortunately, we won't have time to get into details, but hopefully we'll give you all an overview. And then I'll end with talking a little bit about existing breast cancer disparities and outcomes. So as you all know, breast cancer is the most common type of cancer in women. In the US, it impacts almost 300,000 women every year. This is data from 2023. And it's also the second highest cause of cancer-related deaths, with about 43,000 individuals dying from breast cancer every year. There's multiple different risk factors that we've been able to identify thus far. Some of them are listed here. The most significant ones, honestly, though, are being female and having an advanced age, essentially. There's other risk factors, such as having underlying genetic mutations, specifically BRCA1 and BRCA2, tend to have the highest risk for causing breast cancer. There's other mutations that are also associated with this. I haven't listed them all, but just know that there's several different mutations that have been identified in this space. Certainly, family history is also very important and can certainly lead to increased risk of breast cancer. Increased estrogen exposure, so either through starting periods very early, undergoing menopause very late, or having exogenous hormones, so hormone replacement therapy for a prolonged period of time, can also be associated with development of ER-driven cancers, so estrogen-driven cancers. Having underlying dense breast, this actually has been shown to be to lead to increased risk of breast cancer, and this is independent of the fact that individuals who have dense breast, when they undergo screening mammographies, we can have a harder time identifying subtle lesions for those patients. So independent of that fact, they still have been found to have increased risk for developing breast cancer. Similarly, individuals who have atypical lesions that are not necessarily cancer that have been identified can have increased risk. Prior radiation therapy, so for individuals who've been treated with high doses of radiation, for example, patients with certain types of lymphoma, if they've received that to their chest or chest wall prior to age 30, they can be at an increased risk for developing breast cancer. From a reproductive standpoint, so individuals who've never had children or who have had delayed child rearing, so after age 30, having their first pregnancy, or have not breastfed, can have increased risk. And then more recently, there's increasing data showing that obesity and alcohol can also lead to increased risk. This isn't an exhaustive list. There's certainly other things that can contribute, but this is kind of a general list to give you an overview. Now, with screening recommendations, there's several different organizations that each have slightly different recommendations, as listed out here on this graph. Most of them recommend starting between age 40 and age 50, and either doing it every year or every other year. Most primary care physicians, I would say, use that last column's guideline, which is the USPTF guidelines. And they used to say up until this year that average risk women should start at age 50 and have screening mammograms every other year. For individuals between age 40 and 50, it used to be that it was kind of an individual decision based on the patient's preference and their risk factors. Unfortunately, we have started to see that there's increasing cases of breast cancer being diagnosed in younger women, so less than age 50. We don't fully understand why this is happening. There's a lot of thought as to why potentially delayed child rearing could be that. We know that there's increasing rates of obesity throughout the US that can certainly contribute. Alcohol and tobacco use can contribute. And certainly there's concern that there's increasing risk to exposures to carcinogenic pollutants. But there's more and more data coming out, albeit there's a small proportion of patients less than, age 50 or 40 that are being diagnosed with breast cancer when you look at the overall population. But still, due to that, they have now changed their recommendation to now start screening individuals at age 40. And this is more in line with what our ACS, or American Cancer Society, and our NCCN recommendations are. I always like to highlight that this is really for average risk patients. So this is not for patients who have an underlying genetic mutation or have an extensive family history. For those patients, you may very well need to start screening earlier than 40, but at least for average risk women, we're now starting to recommend screening them at age 40. There's some individuals who need additional screening, so high-risk screening with an MRI, and these are individuals who have a known genetic mutation, such as that BRCA1 and 2 I mentioned before. There's ways that we can calculate the lifetime risk of individuals developing breast cancer, and this is predominantly based on models looking at family history. And so if the risk is greater than 20%, those individuals can also be eligible to undergo screening with an MRI in addition to a mammogram. Those who have been diagnosed with breast cancer and have dense breast tissue can undergo high-risk screening as well, or those diagnosed with breast cancer at any age before 50. As mentioned previously, chest radiation can lead to increased risk of breast cancer, and so those who've had radiation prior to age 30 can undergo screening with a breast MRI. And then also, as mentioned before, those with atypical lesions that are not yet classified as cancers can also undergo high-risk screening. So when it comes to diagnosis, at least in the US, the vast majority of these are happening with a screening mammogram. This is usually followed with another type of mammogram, which is called a diagnostic mammogram, that gives us slightly better images and evaluation of the area of concern. We typically do ultrasound at the same time as a diagnostic mammogram to help us define the full extent of disease, see whether there are lymph nodes that are involved and where they are. We do also do breast MRIs and contrast-enhanced mammograms for some patients, again, to really get an idea about the full extent of disease, and we biopsy the lesion. So with regards to subtypes, there's lots of different subtypes. The two I'm listing here, the ductal and lobular, are the most common that we tend to see. The ductal is by far the most common subtype of breast cancer. This makes up about 70 to 75% or so of all diagnosed cases. And this is really developing in the ducts of the breast tissue, as opposed to lobular cancer, which is developing a little bit further back in the lobules of the breast tissue. And that's typically where breast milk is produced. The lobular cancers can sometimes be a little bit more challenging to diagnose early on, just because of how they grow. They don't tend to form masses and lumps similar to ductal cancers. And so these can sometimes be difficult to image on conventional imaging. With regards to another way of classifying breast cancer, so we typically look at the estrogen, progesterone, and something called a HER2 receptor. These are all receptors that are on breast cancer cells. And so if a patient's tumor expresses all three of these, they're triple positive. If it doesn't express any of them, they're triple negative. If it expresses either estrogen or progesterone receptor, but not HER2, then it's considered hormone receptor positive and HER2 negative. With regards to staging, this can be anything between stage 0 to 4. Stage 0 is really referring to patients who have DCIS, or non-invasive cancer. So it hasn't really had the opportunity to break through the ductal barrier and invade nearby tissue. So it's all localized within the duct. Stage 1, 2, and 3 are all invasive cancers, and these are either early stage or local regional disease. And the difference between 1, 2, and 3 is really dependent on how big the tumor is and which lymph nodes are involved, if any. And then stage 4 is really where the cancer has learned to grow outside of the breast tissue and the regional lymph nodes in the breast tissue. And unfortunately, that's when breast cancer can become incurable. With regards to treatments, these are conventional treatments. So surgery, radiation, systemic therapy all come into play. With regards to surgery, typically it's a lumpectomy or a mastectomy. So a lumpectomy, just part of the breast tissue being removed. A mastectomy, all of the breast tissue being removed. For the vast majority of cases, as long as it is possible and feasible, we tend to prefer a lumpectomy because it's a less, it's an easier procedure to recover from with less complications. A mastectomy certainly can be considered for some patients, especially, for example, if they have underlying genetic mutations. We would prefer this over a lumpectomy to reduce their risk further of developing new cancers. And there's other instances as well where we might recommend a mastectomy over a lumpectomy. Radiation is recommended for most patients who get a lumpectomy, but this is not necessarily needed for every single patient with breast cancer. There's other high-risk patients as well where we would consider additional radiation even if they've had a mastectomy. And systemic therapy is really what I do, which is giving various medications to try to treat breast cancer. And so to go into a little bit more detail for that, so this is all for early stage disease, so not metastatic or not stage 4, but for patients who have hormone receptor positive, HER2 negative disease, really all of those patients would have a recommendation to be treated with hormone therapy to try to reduce the amount of estrogen that they have in their body. Some of these patients who have much more higher risk disease can actually be recommended to also be on some newer targeted treatments that we've started to treat patients with over the last couple of years. Chemotherapy is not indicated for all of these patients. There's actually molecular tests that we can send to help us identify which patients have higher risk lesions or higher risk biology, I should say, that would allow them to benefit from getting chemotherapy. So these are tests that are called Mammoprint, Oncotype. There's several other ones that are available. And if they come back showing that they have a molecularly high risk cancer, then those are really the only patients in this subgroup of breast cancer patients that would benefit from getting chemotherapy. For patients who have triple negative disease, so their tumors don't express any of the 3 receptors we talked about earlier, these patients are treated with both chemotherapy and immunotherapy. Currently, these are the group of patients that unfortunately can have more aggressive disease course and disease biology. These are the tumors that can have the worst prognosis of all the 3 different subtypes of breast cancer. And up until recently, the only way that we treated these was really with chemotherapy. But now we've started to treat these patients with immunotherapy because we've had lots of studies that have shown that there is benefit to adding immunotherapy to chemotherapy for these patients. So hopefully in the future, we start to see that the outcome for these patients will be different now that we're using immunotherapy for these patients. And HER2 positive breast cancer, this is treated with both chemotherapy and HER2 targeted therapy. This subtype of breast cancer actually used to be the one that had the worst prognosis of all the subtypes, but HER2 targeted therapies have completely revolutionized our field and have completely changed the prognosis for this subgroup of patients who now actually do really well with HER2 targeted therapy along with chemotherapy. And then, of course, we, at least here at our site, we have clinical trials that are available for many patients. The one I'm showing here is a schema of a trial called I-SPY 2, which is a trial for patients who have high risk but early stage cancers. And this is really a way for us to test many different types of newer or novel agents to see if, one, they can be more effective than the standard treatments that we have available, but 2, to see if they can be associated with less toxicity. So basically, can we achieve the same outcome or better outcomes with less toxicity for patients? So this is really exciting in our field. Over the last decade or so, you can see on this figure that this is not just for breast cancer, this is for all cancers, but there's been a dramatic increase in FDA-approved drugs for many different indications in cancer in general, which has been exciting as it allows patients to have a lot more options than they did in the past. And this is actually very similar. If you look at breast cancer, we have many new drugs that have come about in the last decade, and even in the last 3 years. We've had lots of changes in how we treat breast cancer, and we've had many newer options that were not available even 5 years ago for patients, which is really exciting. And so we have seen, in part because of all of these new treatments that are at times can be much more effective than what we had before, that the mortality related to breast cancer is declining in the US over time. And this is in part, this is shown in the red line at the top. So this is in part certainly due to the treatments, but it's also in part due to the improved detection and just education for patients to present earlier if they're concerned about anything. And so all of those things together have really improved outcomes for our patients. But if we look a little bit further and we actually stratify this and look at which patient groups actually have declining mortality from breast cancer, in general, we see that the decline is really there for all groups. But if you look a little bit closely, there's actually disparities in how this is occurring over time. And so the folks that are represented in the yellow line at the top are Black individuals in the US, who unfortunately have the highest cancer-related mortality of any ethnic and racial group. And if you look specifically at breast cancer, again, you see that the rate of getting breast cancer and dying from breast cancer actually differs pretty significantly among various ethnic and racial groups in the US. And if we focus in on Black women, so in the light green figure, Black women actually have a slightly lower incidence of developing breast cancer. It's about 4% lower compared to white women, but about 40% higher risk of dying from breast cancer, which is shown in the dark green figure. And so as to why these disparities exist, I could give an entire talk just on this topic. The bottom line is that it's very complex and there's lots of different reasons that contribute to why we're seeing persistent disparities over and over. Part of these issues can be explained by social or economic factors, behavioral factors, but all of these honestly only partially account for the disparities that we're seeing. One way that I like to think about health disparities in general, not necessarily as they relate to breast cancer, but just even for health in general, is really to frame it in the context of social determinants of health. And so these are really contexts in which people are born, raised, live, and these can shape their overall health and determine their outcome. And these social determinants are linked to a lack of opportunity or a lack of resources to basically protect, improve, and maintain one's health. And so they can, these various contexts mediated through structural issues like discrimination and racism can actually impact individuals' health. And so we unfortunately don't have time to go through every single one of these contexts, but I at least want to just give examples of these three here: economic stability, neighborhood and environmental factors, as well as our healthcare system. So with regards to economic inequalities, we know that Black individuals in the US unfortunately face a disproportionate level of poverty compared to other groups. And this is important because when we think about how poverty is associated with breast cancer survival, we know that poverty is actually associated with lower breast cancer survival rates. So this is a study from a couple years ago now where they looked at patients who had non-metastatic breast cancer and looked at neighborhoods. They basically measured neighborhood level disadvantage. And the quintile 1 is basically representing individuals that were most affluent. And then quintile 5 is representing neighborhoods that were the least affluent. And even after going and adjusting for multiple different patient level factors, including income, education, et cetera, they still found that those who lived in the poorest neighborhoods had the least breast cancer survival outcomes. Poverty also impacts insurance status. So this is data from 2019 and 2021. And you can see here, if we're just looking at Black and white individuals, Black individuals are more likely to be on public insurance or are more likely to be uninsured compared to their white counterparts. And this becomes important as we think about insurance status and its relationship between the stage at which individuals are diagnosed with breast cancer. So compared to privately insured individuals, women who are on public or who are uninsured actually have a higher rate of being diagnosed with advanced breast cancer. So that's shown here. That bar graph there is representing the uninsured population. And of those who are being diagnosed with stage 4, the vast majority of them are uninsured, as compared to if you look at those who have early stage disease, the vast majority of those patients are really individuals who are on private insurance. And when, in this study, at least when they looked at it further, nearly 50% of the observed racial and ethnic disparities in the higher stage of breast cancer diagnosis was actually found to be mediated just by healthcare or health insurance coverage. And this is important because it impacts survival. So if we just, and this is from the same study, if you just look at the stage at diagnosis and whether patients were insured or uninsured, so the private insurance or uninsured, those who had private insurance are shown in blue here. And at every stage of disease, they are faring much better in terms of survival than those who are uninsured, which is shown in red. And we also know uninsured status can impact behavior. So a lot of women with insurance issues who are underinsured or uninsured can end up delaying certain care or putting off preventative services, mainly because they're concerned about cost. And so here's a situation where you have a specific social determinant of health, which is socioeconomic issues that are impacting behavior. And I put choices in quotes here because these are almost forced choices. They're not purposely choosing to delay their mammogram, et cetera, but that's the choice that they have to make. And unfortunately, that ends up leading to poor outcomes for them. So if we move on to the second context I wanted to just address briefly, this is the neighborhood and physical environment and how that might impact breast cancer outcomes. This is a really brilliant study out of Atlanta done a couple of years ago, where they looked at how where people live impacts breast cancer mortality. And so they looked at neighborhood level redlining and lending bias and how that might be associated with breast cancer mortality. So redlining was basically the systematic denial of mortgages based on place. This predominantly inhibited the ability of Black communities from successfully applying for and getting mortgages in the past. And they used this as a proxy for basically being able to measure structural racism within the community within that neighborhood and what the potential downstream effects from that might be. And they found that individuals who lived in these red line districts had a higher breast cancer mortality compared to individuals who did not live in these districts. And what was really interesting was that this association was actually much more stronger and much more pronounced for white women who lived in these neighborhoods, suggesting that when white women were exposed to the same degree of economic and spatial and social deprivation that Black women were exposed to, they essentially experienced the same poor outcomes. So this tends to argue against the idea that there's something inherently biologically different about Black patients that ends up leading to poor outcomes, and really highlights that our neighborhood has, and some of the structural issues that come with that have a lot to do with outcomes. And this makes sense if you think about it, because not just Black women, but a lot of women end up living in neighborhoods where certain resources may not be available to them. So if we're thinking about breast cancer, for example, they may live in neighborhoods without access to 3D screening mammography or certain specialists to read those mammographies. And so that can certainly impact their ability to be diagnosed early and on time and get appropriate treatment. And the third context I want to highlight is really the healthcare system. This is one study I want to highlight from North Carolina, where they looked at delays in diagnosis. So they looked at about 730 women and looked at how much time it took for them to go from having an abnormal screening mammogram to getting a diagnostic mammogram and biopsy, and basically calculated all of that time to see how much time it took for each individual to undergo through that whole process. And this is important to measure within healthcare systems, because if patients are getting delays in diagnosis, that can potentially end up limiting their treatment options and increase their mortality over time. And so in this study, they found that there was about a twofold increase in delayed diagnosis for Black women compared to white women. And unfortunately, that delay was associated with increased breast cancer mortality after they went ahead and controlled for lots of various factors, including insured status and socioeconomic status, neighborhoods, etc. And in other studies, which I didn't have time to put in here today, when they looked at similar studies like this and then went ahead and actually put in standardized practices into their healthcare system, they found that it's not just the care of Black patients that improves, but it's actually the care of every patient that ends up improving. And so really putting systems into place into our healthcare system and other systems to actually standardize how we treat every patient to ensure that we're delivering equitable care is really important, so that we can improve care, not just for patients of color, but all patients. So I'm going to end with this figure here, which I really like. It's there was a psychologist in the 90s who coined this term, the weathering hypothesis. And it's really the idea that the chronic and repeated exposure to social and economic disadvantage and marginalization and structural issues like racism can actually end up leading to accelerated decline in individuals' physical health and outcomes. And this can actually partially explain why we're seeing racial disparities, not just in breast cancer, but in almost every single type of disease that we could pick. And so I would argue that we have existing health disparities, not just because of biologic issues or socioeconomic issues, but it's really the interplay of all of these structural issues that end up leading to psychosocial stressors and physiologic and behavioral responses to those. And sometimes actually even genetic and genomic responses and alterations that can end up leading to certain populations having worse health outcomes than others. With that, I will end. Thank you so much.
Dr. Idossa, thank you so much for providing such a thorough and informative presentation in such a short period of time. And as you mentioned, each topic that you covered, could be its own presentation, but yet you were able to introduce them so well. And so we will be digging a bit deeper during our discussion today. So stay tuned for everyone who's on today. So next we will be hearing from Steph Kennelly, who will be sharing her personal breast cancer journey. Steph is the program coordinator at the University of Minnesota Center for Genome Engineering. Steph was diagnosed with breast cancer in 2020, now in full remission. She is thrilled to join the team bringing new therapeutics to clinics. In her free time, Steph volunteers her time as the founder of the GVL Thrive program. This program partners with Minnesota nonprofit, the Indy Foundation, and resort destination Grandview Lodge to provide respite vacations for individuals in cancer treatment. She's also passionate about the healing properties of breathing, singing, movement, rest, and social connection. I am honored to introduce you all, Steph. Steph, please take it away.
Hi, everybody. Thank you so much. And Dr. Idossa, that was a fantastic talk. So grateful for all the work that you're doing in our community. So with that, I have some slides as well. I always like to start my talks with anyone I have with a disclaimer that everybody's cancer is different. And this is just my personal experience. I'm not a doctor, so I can tell you about my experiences and my decisions, but that does not mean that it is right for everybody or right for you. And just like Dr. Idossa, I have so much to say that I won't get to it all today. So please connect with me. You can find me on Instagram or my Medium channel, where I've shared some blogs about breast cancer as well. I love connecting with people, so feel free to reach out after this talk as well. A little overview of my journey. I was diagnosed almost 3 years ago on November 27th, 2020. My treatment was double mastectomy, chemotherapy, reconstruction, tamoxifen, fat grafting, hysterectomy and oophorectomy, and exemestane. So that's kind of the process I went through. And then I just included that picture because I think it's funny. So in my 40th birthday this year, I jumped into a frozen lake up north and was reborn. So so here I am now. And thank you everybody that took time to put questions with your registration, because I sorted my talk based on some of those questions. So thank you very much for doing that. One of the questions I had was, how did you find out you had cancer? And I found my cancer during a self-exam in the shower at age 37. Like Dr. Idossa said, that if I would have followed protocol and waited till age 40, who knows if I would be here now. So I always tell everybody, take time, slow down, listen to your body, know what's going on, be an advocate for your health. So anyone that'll listen, I try to talk about the power of self-exams. Then after that, a lot of times people are like, well, how did you tell people? And to be honest, I sat with the information for a couple of weeks before we told me and my husband decided to tell anybody. I had a session with my therapist and I said, I really am dreading telling people. And she said, well, why? And I said, I just don't want people to say sorry. She's like, well, what's that about? Why don't you want people to say sorry? And for me, when, as kind of an empath, when people might have said, oh, I'm so sorry, then it was me managing not only my own emotions of being diagnosed with breast cancer, but managing my emotions of dealing with their emotions. And so she said, just be honest and tell people how you want that interaction to go. So here was my social media announcement. I kind of blanketed it on Facebook and Instagram, and then said, you know, if you'd like to join on this journey, email me and I'll give you the private link to my Caring Bridge. So for me, if you are newly diagnosed and you're trying to navigate how to tell people, this was kind of my way of telling people, but then also having kind of an inner space for the people that wanted to join the journey. And I was just blown away by, you know, old high school friends, neighbors, people that I really hadn't talked to in years joined my Caring Bridge and were instrumental in the support. And so that, and especially during the pandemic, that was a huge piece of my healing journey. So this is my Caring Bridge page. They have amazing resources. I would journal almost every day, blogging my experience. They have great ways to organize help and with the planner, and I'll talk more about that as well. And I just included this from my friend Jackie, wrote this for me after she learned about my diagnosis, and the power of having everybody in the community wishing you well and supporting you with positive thoughts and prayer, I really believe does help the healing journey. So there is power in kind of building your community. So then a lot of people say, how can people help? You know, you're newly diagnosed, that's going to be a question. If you are newly diagnosed, you'll get, how can I help you? And so I really recommend creating structures and lots of options. And so then if people say, how can I help? If you do have a platform like Caring Bridge, you can say, you know, I have a lot of ideas on my Caring Bridge page. I'd invite you to go visit that and help in any way that you're comfortable. So here are some ideas that I put out to help people. I did set up a calendar where I would have a quality time phone call every day at noon. And this was really helpful because a lot of times people want to reach out, but they don't want to bother you. it's like, oh, well, you're going through a lot and I don't want to be calling and, burden you. But this way people could sign up. I knew the call was coming. They knew the call was coming, which was really helpful. Some other ideas: household chores, childcare, food. Be specific, unless you want 25 lasagnas, being really specific about the type of food that you would want. Amazon wish lists. I do have a blog on this. I also had people send earrings when I lost my hair, hats and head coverings, Christmas tree ornaments. And then just thinking, what are your talents and what can you contribute to somebody who's newly diagnosed? It might be playing a song on the piano and texting it, or I had a friend write me a poem, or art. So just thinking about ways that you can show that you care is really important. Here are a couple different ways that I just wanted to highlight. Cheap, free sidewalk chalk. I had some friends come and do sidewalk chalk art on my driveway before my first chemo. I had a friend that bought me a juicer. And so instead of getting, cookies or baked goods, I asked people just to buy me fresh fruit and vegetables every day. And so every day I'd get a bag of fruit and vegetables on my porch, and my mom and my mother-in-law would juice me fresh juice. So when I didn't feel like eating anything, I knew that I would have fresh juice every day to keep my nutrition up. I had a friend donate a photo session, which at first I was like, oh, well, I don't know if I want to document this, but those photos are some of my favorite things that I own. And room art. I had a little heart template that friends colored, and I hung them all up over my walls. So those are just some things I wanted to highlight. Who are the other helpers? Like Mr. Rogers says, find the helpers. So who are your helpers? Who are in your community besides your friends and family? So it's your doctors, it's your medical team, nonprofits, and then the cancer community too. So my biggest suggestion is that if you are newly diagnosed, is to find a doctor that you resonate with, especially your medical oncologist, because that is going to be someone that's not just with you for your treatment, but probably for a long time. So in that first couple, appointments, if it doesn't feel good or it doesn't feel like a match, there's no harm in saying, I don't think this is a match. I'm going to try to find another doctor. This is just this isn't even a complete list of my medical team: physical therapists, medical oncologists, OBGYN, plastic surgeon. And I just adored my medical team. So they were the biggest helpers. And then here's some of my other nonprofits. Cleaning for a Reason is a great nonprofit that came and cleaned my house top to bottom. Angel Foundation, Indie Foundation, which I'll talk about later, that I have a partnership with. Haley Strong, Hope Chest, Hope Scarves, Open Arms, Minnesota, Pathways Healing, Shara Sheet, Stay Beautiful Foundation, Pink Wig Project, and Verma Foundation. And I'm happy to chat more about those too. So this was a good question: is how did you cope emotionally? And I like to think about the way that I dealt emotionally as almost like a Chinese finger trap. And I think a lot of times one of the reactions can be to pull against. And this idea of acceptance, that you can relax and ease into the process, can be helpful, right? You ease into it, and that's how you get out of the finger trap. And also being able to hold space for both is having space for the joy and the gratitude, and also having space for the anger and the fear, and being able to hold both of those. I had a little Post-it note by my bed that I wrote. I said, I accept the healing change. So how I'd phrase my treatment when I felt horrible is I'd say, okay, this is just a healing change. Like during my chemo, I'd sit in the chair and visualize a golden ball washing away the cancer. And that kind of framework can be really, really powerful. So that was kind of my biggest takeaway for how I coped emotionally. And also just having connection. The picture in the middle is during one of my chemo sessions. My friends and family Zoom chatted me and did a little, we're pretending we're all hugging, did a little mindfulness practice during my chemo session. The one on the right is all my neighbors celebrating with me, of course, masked and distanced. And then on the left, I have a blog post about this. I'm a pretty active mom, and I just didn't have a whole lot of energy during my treatment. And so me and my son would play Roblox together, just figuring out a way that you can have that connection. And really just getting outside. That I live in Minnesota, and even in the winter, my husband would bundle me up and sit me out in the fold-up chair just to get some fresh air, vitamin D, sunshine. That was really crucial too. How do you deal with being a survivor? And I actually put thriver in quotes. A dear friend of mine is a stage 4 cancer thriver. And that's kind of a word that their community has embraced. This idea of surviving can sometimes, for some people, be a little bit more negative than thriving, right? Like, I'm not thriving in spite of my cancer. I'm almost thriving because of it. And so that's a way that I have embraced as well. And for me, I'm really paying it forward. The biggest thing that I tell people with, finding the helpers and accepting the help is that, what, this is your season to accept the help, and this is your season to heal. And eventually, if you're on 2 solid feet, then you can pay it forward. So that's been a really big part for me. I do mentoring through the Firefly Sisterhood. It's a nonprofit that matches support seekers with support givers. And in this picture, the woman in the middle was my mentor, and then the other woman is now my mentee. And so just having that connection with someone who kind of understands what you're going through. If you are in treatment, that is a great free resource. And giving back, like they mentioned, I have partnered with the Indy Foundation to start the program GVL Thrive, where we bring Minnesotans in cancer treatment up for a free vacation with their family. That's been also a huge piece in staying connected with the community and being able to give back the resources that I have. And so the owners at the resort donate their units. And also recently, like was mentioned, I, in May, took a job at the Center for Genome Engineering. During my treatment, I just felt very called to help support the cancer community. And the doctors there are doing amazing research. One specifically that I wanted to highlight was a clinical trial where they are investigating genes that determine how much white blood cells are in a tumor. And so really exciting stuff that I'm happy to lend my talents to and support. And then one of the questions that I thought, oh, wow, this is an interesting one. How have you changed? And the answer that I like to give is that I feel almost like I'm more of the person that I'm meant to be. That kind of like the metaphor of the coal under pressure becoming a diamond, or the butterfly in the cocoon. I really have just been able to find my voice and find my confidence and become more of the person that I think I was really meant to be. And so with that, I will kind of throw it back to see if there's any questions.
Oh my goodness, Steph, thank you so much for taking the time to share your beautiful story with us today and how you navigated through this journey. You're truly incredible. So we have, unfortunately, just a few minutes for Q&A, but we'll get right to it. And if any of you have attended previous Fireside Chats, you know that it's not a Fireside Chat discussion without getting our fire started. So I'm just going to go ahead and quickly do that. But let's just kick things off. So Dr. Idossa, I will actually start with you for this question. So this person specifically asked, what are the screening recommendations for survivors who receive the double mastectomy?
That's an excellent question. So if you had a bilateral mastectomy, the current recommendations are really for physical exam and a history at least every 3 to 6 months for the first 5 years. That tends to space out a little bit more as you get further out from treatment. But unfortunately, there aren't any kind of routine imaging that is recommended because old studies didn't show that they improved outcomes if there's no breast tissue for us to really image. Obviously, that's different if someone is feeling something abnormal. At that point, we can get imaging to take a look further. There is newer data kind of looking at circulating tumor DNA. So trying to do blood tests to basically see if there's any evidence of recurrence. And that field is definitely very exciting, but not quite ready for clinical practice yet. But we're all hopeful that hopefully within the next few years that will be available for our patients.
Right. I do really appreciate the comment about just really listening to your body. And so, if anything abnormal comes up, making sure that you are addressing that with your clinical team. So thank you for that. So this question was submitted. This individual said that they were recently diagnosed with DCIS and they're getting great care. That's wonderful to hear. They would love to know more about some holistic and some contemporary practices that they can add. So I actually will start with you, Steph, and then Dr. Idossa, if you have anything to add as well.
So for me, I was open to everything that that would have helped. And I actually, my oncologist recommend acupuncture. I didn't mention this in here, but I did have a double mastectomy, and I know that Dr. Idossa said there can be complications. And I had a complication called cording that limits your mobility. And so it was really helpful for me to have acupuncture. That is one of the things that kind of brought that around. So that was one of the treatments that did help me.
Thanks, Steph. Dr. Idossa, do you have anything to add?
Yeah, I think if there's certain symptoms that are, concerning, as Steph mentioned, certainly adjuvant treatments like acupuncture and massage and things like that can be very helpful. I think from something that I think about from a trying to reduce a risk of recurrence standpoint is what we can do in that space. And we have really great data to show that maintaining, good physical exercise, at least 150 minutes per week with at least 2 days of strength training can be very helpful to try to reduce the risk of recurrence. We know that maintaining a good, healthy, well-balanced diet is really important. Avoiding smoking, excessive alcohol, all of those things end up being very important in the survivorship setting. And I think certainly there's some long-term issues that can come up from treatments that people have gotten. And so ensuring that, people are plugged in with good mental health support, good community, and things like that as well.
Great. You definitely both just knocked a few other questions that were submitted. So I'm seeing some questions in the Q&A. So some kudos to both of you. Wonderful talks from both of you. And so the slides will be made available. So they will be included in the post-event survey that will be sent out tomorrow. So you'll get the links to the presentations. And so there is another question, and it's for you, Steph. How do you feel about Pinking of October? This is, so there's products in grocery stores bearing pink labels, ribbons, and other things that pop up each year. I know a survivor for whom, while the company's intentions are notable, this is a difficult reminder of her breast cancer journey. So Steph, I'll start with you, and then Dr. Idossa, if you have anything to add.
Yeah, I also have noticed that. So great question. And I think that if you are purchasing an item hoping that the money is going to go to breast cancer research, more often than not, it's a marketing tool. And so there are some people in the breast cancer space that feel like it's a little exploitative. Yeah. And especially some marketing efforts can even kind of like hypersexualize breast cancer. And there are men that get breast cancer. And so just to be really careful about what your intention is. And everybody responds differently. That being said, I definitely am a joiner. Like my closet is full of maroon and gold, you know, and so I do have some pink stuff and pink ribbons. And I also am very careful when I'm donating my money or speaking about it, that I'm doing so in a way that is mindful of the different perspectives.
1000% what Steph said.
Keep them coming. We have a few minutes for Q&A. So if you have any questions that you would like answered, please submit them through the Q&A. So let's see here. So I'm looking at some of the questions that were submitted via the registration. So Dr. Idossa, this actually is a question for you and Steph based on your experience. You can address this as well. But Dr. Idossa, in your studies, have you found any specific challenges that are unique to young women diagnosed with breast cancer that might differ from older patients? And how are these challenges being addressed?
Yeah, I think excellent question. I think in general, I think young women in general can sometimes have a hard time just being believed that there is something abnormal that they're feeling. And so it can sometimes take a little bit longer for them to get diagnosed, because a lot of times it can be attributed to, oh, it's just a fibroadenoma, or it doesn't really happen as common in your age group. So they sometimes will need to advocate for themselves a little bit more to really get the proper imaging that they need to get the diagnosis. So I know that can be a challenge for a lot of our patients. This especially can be a problem for patients, for example, who've recently given birth or who are breastfeeding, because a lot of times that can be attributed to a clogged duct or things like that. And when patients are breastfeeding, it can be more difficult to get imaging because there's a lot of just changes that happen in the breast that can make our imaging modalities a little bit more challenging to get. And so I do see that those patients can also sometimes get delayed diagnosis. And as I was mentioning in my talk, it's really important to get diagnosed fairly early so that treatment can be started early, as that can impact outcomes. So that's what we see a lot of. We also see that the biology of cancers that are diagnosed in women that are younger it tends to be different. It tends to be one that people tend to feel on exam, as opposed to a very slow growing cancer that is just incidentally noted on a screening mammogram, which sometimes it can behave a little bit more aggressively. So all the more reasons to really advocate and get appropriate treatment and diagnosis early on.
Yeah, and I would agree with that. As I've been talking to more women in the space, I think the reason I found my tumor is I often would get mastitis when I breastfed both my boys, and my tumor was in like almost the same exact location as where I would get mastitis. And I've heard a lot of other women say that. There are a lot of support groups for young women diagnosed with breast cancer because it is different. You know, I was 37. We were done having kids, but there are women that get diagnosed and do want to get pregnant again. So there are complications with that. Like I mentioned in my talk too, my doctor recommended an oophorectomy because of the high estrogen nature of my tumor. And so there are support groups for, you know, freezing embryos, or even I've seen women that have signs after they have birth, if they do have a mastectomy, that says, you know, I'm a breast cancer survivor, please don't ask if I want to nurse my baby. Just things like that, that can lead to some difficulties. But there are a lot of great support groups for young women that are diagnosed.
Thank you so much. I know we are at time, so I want to be respectful of everyone's time. But Dr. Idossa and Steph, thank you so much for your time today and for sharing your expertise and your experience. It was truly a phenomenal session, and I'm seeing kind of comments being made about that as well. So thank you everyone for staying a little bit over. There were so many questions that we did not get through, unfortunately, but we will have to leave it here. And so today, after you close out of your Zoom window, there will be a link to complete a brief survey for us. Please fill it out because it will help us continuously improve our program and future fireside chats as well. And then after submitting the survey, you can actually, there's a link where you can enter into a drawing to win a prize pack filled with goodies from the Masonic Cancer Center. And then also, I know there's a few folks who asked about the employee well-being link that also will be included in the post-event survey that will be sent out, post-event email that will be sent out tomorrow, and will also include a link to complete the survey. And then for everyone who tuned in today, excluding University of Minnesota affiliated staff, students, and faculty, will be entered into a drawing to win a $25 Target e-gift card. So keep an eye on your email because 2 lucky attendees will be receiving that. And then join us for our next fireside chat on November 6th at 2 p.m. And it will be on lung cancer chemo prevention in recognition of Lung Cancer Awareness Month. And so I actually will put in quickly in the chat the link to register for next month's fireside chat. But lastly, please follow the Masonic Cancer Center on all of our social media platforms to stay up to date on our future events and upcoming and announcements as well. And then thanks again, everyone, for joining us. It looks like we need to wrap it up as the video just shown. So thank you everyone for joining our breast cancer focused fireside chat with Dr. Damé Idossa and Steph Kennelly. Have a wonderful rest of your day, and it was truly an honor. Thank you.
Take care.